presentation that we prepared for you to update on what we did in our basically 2020 year cycle, but also what we are planning to do moving forward in 2021. I would like first to disclose that some of the content that you will hear today was presented at the several BPM Plus Health meetings back in June and September of 2020. We had a poster about educational activities at the BPM Plus at the Mobilizing Computable Biomedical Knowledge Conference. You may know that National Library of Medicine and Chuck Friedman are organizing this conference. And one of our colleagues who helped us to work on the project with Duke University, Rachel Richardson, is one of the leads in organizing MCBK conference. We also presented materials of our work at the American Health Information Management Association 2020 Annual Convention, where we specifically targeted a group of professionals they called clinical documentation improvement specialists, which is on a daily basis involved in formulating the clinical pathways as well as the data templates for data capture and electronic health records. So that particular session at IHIMA was very well attended. We have about 100 attendees, and we feel that this particular BPM Plus efforts could be very useful for the specialists working in health information management, medical records, and informatics departments throughout the healthcare organizations. I would like to show you the outline for our presentation. We will talk a little bit about the group and how we fit into overall BPM Plus efforts. Nicole Miller will present section 2 of our presentation on the methodology we use to standardize clinical pathways and developing data templates. And after that, myself and the candidate in our Tufts Health Informatics Analytics program, Angela Reilly, will talk about the pilot projects that we conducted last year and is currently working also in collaboration with the American Dental Association and American Associations of Orthodontists. So we will touch based upon our future projects. We just started working on them last year, and we're looking for a home for them with the professional associations or any other groups who would be interested to help us complete these projects on inpatient fault prevention and revenue integrity. And then we'll talk a little bit on how you can participate in our efforts, how we can learn from your work in education or just standardization of clinical pathways that we could use then in our educational materials. So in this particular portion of the presentation, you all already saw those slides from the previous BPM Plus Health meetings. We're part of this effort. Our group was formed over a year ago in November 2019, and since that, we just really focused on addressing the needs that we believe do exist in healthcare that is implementing electronic health record or other ancillary systems and software applications, digital applications. So we all know that there are clinical guidelines and best practices need to be translated into machine-readable formats. We believe that clinical pathways is a great vehicle to make this happen because it's leading to standardization of business processes and practices across the organization. The problem, though, that exists today, that these efforts are implemented by various organizations in proprietary fashions. Moreover, clinical pathways are usually the documents that are not shared outside of the particular association, a particular organization. And with that, we felt that adoption of standardized practices for developing those pathways and then sharing them across the community would be a great opportunity for us to establish what we called actually functional interoperability, so standardization of rules on how electronic solutions could be deployed, used, and reused in healthcare practice. So what we are part of is this wonderful group of people. You see the pictures of many of us here on the right, and we collaborate in this manner that BPM Plus is following. It's a member-driven organization. Our committee is member-driven. It's a place to collaborate, to learn from each other, and it's the way how we can raise an awareness about standards-based approaches and tools-based approaches to build machine-readable clinical guidelines and data templates. This is just for you to remind what type of BPM Plus modeling standards we are using in our work. And you will see, especially in presentation that Mike Cicina will deliver, of how we can take the business rules presented in particular clinical pathways and translate them into these various models, such as BPMN, DMN, SDMN, CMN, and all of that just could be enabled through the model-driven message interoperability approach. This is the website of our working group. Under the work products here, you can see that we have a strategy and charter document that we developed in November of 2020. We finalized it, but it's a living document. If you have any suggestions for us of how we should move forward, just I would call to this strategy and charter document for you to guide our future activities. We most of the time in the past year focused on supporting the student capstone project with Duke University that I will be talking in this presentation a little bit with the help of my Cecina on child sex trafficking. And that particular project helped us to refine our methodology. And right now, I'm very happy to report that we have a second capstone project of the student from Tufts University School of Medicine Informatics program, Angela Reilly, and she would talk about this project later during this session. As I just showed you on the earlier slide, we had several presentations during last year, and we would continue to publicize our efforts through various national and international forums. And if you have any organizations or any meetings that would be interested to hear from us, please reach out to us and become a presenter or co-presenter of the materials that I will be sharing with you together with my colleagues in a minute. Our goal is to build a professional health, proficient health workforce, to develop standardized computable pathways and implement standardized computable clinical pathways in the IT.
Okay, next slide, please. Okay, as you can see from here, we're we all familiar with the way that data leads to information, which then leads to knowledge. So you can see from this screen how we start with knowledge, which basically is the clinical guidelines and best practices. And then we step into information, which is the clinical pathways, and then step deeper into the data templates. And then we start to go back the other way to information again with the data sets and value sets. And then lastly to knowledge again. So you can see how the clinical side and the administrative side, specifically health information management, can all fit together and how everything meets in the middle with the data that you need to go out to both sides. And here you can see how we have that kind of give you even a better picture where we have the care delivery on the side there where we have the healthcare knowledge, and then everything leads into that. So we have the clinical documentation improvement, which includes the clinical pathways, the case definition templates, leading into quality data, and then stepping back around to data analytics, and then back to the healthcare knowledge. So this can be a continuing circle that you're always reviewing and changing. So you're always working with all three of those concepts, the data, the information, and the knowledge, to constantly be improving that care delivery for the patients as well as the efficiency of the facility. Next slide, please. So here we kind of see that same concept again, where we have all the professional associations up on the top with the ADA, the AMA, ANA, AHA, AAP, and they have all the artifacts, which basically is the guidelines. So we have so they become the guideline manager, which then filters down to the practice manager, goes over to the data sources, and then back to data analytics and back to the guideline manager. So again, we're constantly making that circle with knowledge, information, and data. And here we add on another layer. So you can see how, again, we start with those artifacts, and then we move into the clinical pathways and standard operational procedures. And then from the practice manager, we move into data capture templates, which leads us to the data sources, and then the decision support, which gives us the data analytics, and then to quality measures and the public health reports, which gives us the new knowledge, which leads us back to the beginning of the circle to continue our cycle again. So really, these are just huge cycles that keep going around and round as you can continue to improve, and you can really see how the documentation improvement is the big focus here. Next slide. This is a template of how we've developed a business case and a use case. So you can kind of see how there's each of the steps that you can follow and really create a business case and use case if you wanted to, using all these steps. So it makes it easy to say, okay, I want to create this use case, but how do I do it? So here's a template that you could actually use and see how everything all fits together. Next slide. So here we're taking a deeper dive into that. So you can see we have the business case on the top, and then depending on that business case, we can develop any use cases that are needed to support that business case. And then even a step down further, the realization scenarios and the technical use cases. So you can see how they all fit together and how you have to have the first one and then step down into each of the other ones as you're developing these business cases. Next slide. This is an example of a use case using that template that we just saw that has been created. So you can see how we have the name, the business actors, technical actors, the flow of events, the precondition, postcondition, preferred timing, and then we have the data categories and data flow on the other side. So you can really see how each of this fits together and how it could actually be used as a process for an organization to start to put into place. Next slide. As I kind of mentioned, you can now move into the fire resources, where you can see the whole list of different resources that are out there using fire. And you can use any of these to develop your use case depending on what you need for it. Next slide. So for our example here, we're actually going to choose the patient. So you can see how we really get into the details of that particular patient resource using FHIR that can be used in your use case to develop it into your model. Next slide. Now we kind of have a different view of everything that we're talking about. And this really makes me think of the quality control model that we're probably all familiar with, the Plan, Do, Check, Act, because we start with design, and then we develop it, we test it, we implement it, we evaluate, we deploy and operate it, and then you can go back and start again depending on the knowledge that you learn from your deploy and operate phase. So it's again, it's just a continuous process, and you're always checking to see how it can be improved. Next slide. Now again, I'm going to bring us back to the template that we spoke about earlier. And now I'm going to turn it back over to Dr. Orlova, and you'll actually see from our demonstrations how we've taken this template and actually made it into real life scenarios for our different use cases. Thank you, Anna.
You will see in these demonstrations is that we were trying to show that this methodology that Nicole described, and the methodology that information system development is used on the steps of requirement elicitations were in fact used in our APE educational projects. So the first project we worked on was a patient registration use case, and that's because at that time when Lieb, another co-chair of the APE group, and myself just got together and thought about what plans for our projects could be in APE group. Lee suggested to work on patient registration demographic data capture project, and that was the project that Lee Wise, Nicole Miller, and myself worked during our tenure at the American Health Information Management Association, when we collaborated with Integrating Healthcare Enterprise, RHIA, when we published this white paper with the workflow and data categories needed to support patient registration process. And we viewed the patient registration process as a standardized approach for patient registration across healthcare facilities, and also aimed to define the set of standardized data elements in patient registration process so that we could properly identify the patient, ensure the completeness, correctness of data that we're collecting, as well as eligibility for services and timely payment for these services. And because our use case was using the EHR to ensure completeness and correctness of that process, so we developed the use case, or we actually took the use case developed by AHIMA members in this white paper that I pointed before. And we just basically said that if we could just take this workflow listed here and associated data categories and apply here the modeling that BPM Plus is allowing, it looks like we could have closer to the representing a particular business process using a modeling standards. And what you can see right now is that for specific data categories, we selected using the fast health interoperability resources that related to the workflow that being described in the use case. And in terms of modeling this process, both the business process as well as data schemas, we just collaborated with Mike Cicina using Visible Analyst as one of the tools where this process can be enabled. So what Mike offered us is to use the planning statements to define the clinical pathways. And those clinical statements were focused on identifying the policies, the participants, and specific business processes, answering the questions of why, who, and what needs to be done in the particular business case. And then we transitioned into how these business processes could be described in the clinical pathways, but also modeled. We also added data template because we believe that in terms of achieving interoperability, such as semantic, technical, and functional interoperability, using the definition of HL7 for interoperability efforts, we just feel that modeling just only workflow is not sufficient. We definitely need to bring the data model templates here as well. And the tool that we used allow us to do that. So what you see here is the planning statements for the description of our clinical pathways for patient registration process. And this is the BPM Plus workflow models that we used to describe the business processes as well as the records that associated with those processes. Moving forward, we just developed the data schemas, data models that are reflective of those data requirements that were specified in the use case. And within the tool, we were able to associate them with a particular business rule by each by each flow of events. So we continue to use the file resources here, representing the data types in a particular format that file resources enables us to do. And one of the features of that particular tool that we used is that it allows to publish these models, but then also allow the external subject matter experts.
Thank you, Anna, and welcome everyone. As I just went through, there was a use case that was centered on the patient registration. And here you can read the slide in front of you on the human trafficking and what it entails in terms of its use case. Next slide. So the first step, of course, is to delineate the lineage in the use case. So you can just take a moment and read through the flow of events here. As you can see, pick up the events for the patient, for the clinic involved in the flow of events, and the data categories of what those events relate to in so much as the data sources are concerned. Next slide. And once we understand the data categories, then we're able to identify which FHIR resources come to bear on those data categories, essentially. So you can see your slide some examples of that. And the ones that are key, of course, will be involved with the patient, the practitioner, the event that took place, what happens actually in the emergency room. So there's there's an encounter, there's a triage, and there's an episode of care. So those are the examples of the HL7 FHIR resources that come into play in this particular use case. Next slide. And one obvious, attempt to understand this in designing it would be to come up with a conceptual workflow model. And you can see that on the left, essentially. So that kind of identifies the who and the what and the when something's involved in the workflow itself. Then what one would do is one would translate the conceptual workflow into a business process using the OMG BPMN notation, which is a standard, meaning that then what is represented in that standard is actually computable. In other words, it can be read by a computer, by other tools, and it can actually be, let's say, we can refer to that as a composable business model, meaning that we can redesign and recompose and republish the business model, which gives us quite a bit of leverage in implementing particular workflows. Next slide. So in, let's see, in the tool itself, Visible Analyst, one would first typically begin by defining the planning statements. And as Anna mentioned earlier, these planning statements simply are a way to get your arms around the requirement, okay? And in doing so, you can delineate your requirements into planning statement types. For example, a goal would be a planning statement type, an objective would be a planning statement type, strategy would be another planning statement type. So it's somewhat hierarchical. It could be somewhat of a form of a taxonomy. The idea, again, is to make sure that you've essentially identified the requirements. You can include the requirements in your planning statement descriptions, links to any URLs that come to bear on that particular description would be included also. And in doing so, then you're able to link these planning statements to all the other objects and artifacts in the underlying repository. Next slide. So when you're able to identify the composable, if you will, composable business model, you then are able to represent that business model in BPMN, as you can see here. And at the same time, you're able to draw the relationship between any artifact or object in your business model back to any requirement that you had set up, whether it be a goal, an objective, or a strategy. And in fact, in this particular business model, you also have a reference to something called data objects. And a data object is essentially a place where the data is stored and comes into play at some sequence or some point in time in the overall workflow of the business model. And here you can see that there are 3 identified in this particular case, which I'm having a little difficulty reading, but I think, okay, the patient registration record, the initial triage record, and the green bomb survey results. So in identifying a potential victim of human trafficking or child sex trafficking, what would probably happen in the emergency setting is that there'd be initial triage done. There would be an encounter, of course, a record of the encounter of that individual in the emergency room. And depending upon what path the business process takes or the pathway takes you, there may also be included in that a survey. And the survey, typically it's used as a survey instrument, which some of you may be familiar with, called the green bomb survey. Next slide. Given the fact that there are these data objects in the flow of events, in the workflow, there's also the opportunity to, like we were able to link the planning statement to any particular object in the workflow or the business process, we are also able to link any data object to the actual entities that are referenced by that data object. And when we do this, what we're doing is we're actually referencing an entity as defined within the FHIR HL7 resources. So here we are able to come full circle and link the actual data collected in the business process to the representation of that in the FHIR HL7 specification. Next slide. And once that is achieved, then we actually can query the instance data. So we've moved from basically the conceptual data through the logical data, and here is a slide showing that we can directly relate some step in our business process to the data. So we can query that data and in real time understand what our next step is in the actual pathway. And
so I will be talking briefly about the dental referral business case. Next slide, please. So for the business case, we, as with other healthcare fields, dental care is very dynamic, and it's a very collaborative clinical process that connects, general providers with specialists and patients. And so the patient data needs to be accurate and safely transferred so that the provider-patient experience is cohesive. And so we identified, 3 specific areas in the patient visit scenario: the office operation, the general dentist visit, and then the specialist visit. And so 2 problems that were identified was, what and how data is captured during the dental visit with the general practitioner. And then the second problem was a lack of consensus on what data is needed and shared for the referral process. And so the IT solution proposed is one that can support the referral process by sending and receiving accurate patient data from one provider to the other across multiple information systems, so that continuity of care is increased and the orthodontic referral process is safely expedited. Next slide, please. And so the use case I'll be presenting on is the orthodontic referral, which is currently under public review, and I'll talk a little bit more about that in a second. So under workflow on the left is basically the steps that were identified from the point of registration or, scheduling an appointment with the general dentist up until the patient goes to the orthodontist and then comes back to the general dentist. And so basically the goal is to create like a bi-directional, cohesive transfer of information from one provider, so the general dentist that first examines the patient and then has, a dental assistant or some other entity, business actor, input that data into their EHR. And then the general dentist then refers the patient to the orthodontist for treatment. So the traditional referral process. So the critical step here would be step 4, where the general dentist refers the patient, and then the referral is created in that first EHR system. So now, the conceptual goal is to have the orthodontist see that referral reflected in their EHR system so that they can then add their information, and then the information is in one place. So it's, as I said, a cohesive, transfer of data that's accurate, and, we can see it and access it. And so from there, on the right, you can see the data categories that were identified by event as they connect to the clinical pathways, the workflow, and the data flow. Next slide, please. And so these were the FHIR resources that were identified in the dental referral business case that pertain to the data categories as they're identified here on the left. Next slide, please. So this was an activity diagram that I developed for purposes of one of the courses that I completed last semester. And so it's not following the BPM models. However, those models will be developed in order to adhere to the BPM standards. And so this was just basically my interpretation of the flow of data and, you know, where the data is starting, where it's going, and then eventually where it ends up. And so this leads to next steps. As I mentioned, currently the use case is under public review, which means I developed a public review instrument with my preceptors. And so that is in the process of being distributed to current providers, general dentists and specialists. We solicited their advice and their feedback and asked them to be subject matter experts for their expertise and their feedback on this proposed use case and the proposed standardization processes for the orthodontic referral use case.
Our member from University of Kentucky Healthcare came up with the idea of this use case, and she just followed the same approach we suggested for her, defining the business case and the use case to correctly document information on inpatient fall prevention within the healthcare facility. She developed also the workflow and associated data categories under this use case description, which we are planning to also move through the process of public review in the future. She began working on identifying the type of file resources standards that needed to depict the particular categories of data she proposed to be collected, and that part of the effort will also be under public review in the future. She started to develop the workflow diagram here using BPM models, and the reason why I really would like to show you this diagram, because you saw throughout this presentation that we're beginning with the diagrams that may be more intuitive, and that's what users put them, but we put them in or describe them in. But then it would just really take extra efforts of modelers, BPM Plus modelers, who will be working with us. An example here is, for example, is the Mike Cicina effort, just to put those workflows of the clinical pathways as well as these initial diagrams and translate them into the artifacts in a particular tool, where then they could be compared, reused, assembled, and reassembled in the context of the episode of care. A project that we put together as an initial project last year, there was revenue integrity. That's again the process that's very instrumental and important for every healthcare organization in the US, because it goes to the reimbursement for services, and we defined the revenue integrity business case as well as a use case that would allow us properly document the episode of care visit, as well as ensure that this documentation all verified through the process of integrity verification, revenue integrity verification, shared with payer organizations, and eventually just submitted for payment, which is in turn provided in a timely manner. So these are the abbreviations we use throughout the presentation. This is the educational committee, and therefore we're following this like academic standards, so that not to use the alphabet soup, but here it is with the clarification. And in conclusion, I just would like to say a few words about how we see our next steps. Through these processes, through this project that you just saw, the 3 active projects, patient registration, child sex trafficking, and dental referral, we're refining our approach. We would like in the future to collaborate with other BPM Plus group, so they could give us their artifacts, their business cases and use cases, so we could put them into our educational materials. We definitely need and plan to collaborate with the BPM Plus Health Tooling Group that was formed a few months ago, because we strongly believe that all these artifacts can be enabled only through the tooling process, not through these endless Word documents on PDF publications. And of course, we're looking for collaborators working with us together on the new projects. We would like to recruit new members who would not only bring their new projects, but also may be interested to become the speakers on our behalf and help enable BPM Plus adoptions in their organizations. Here we are. We look forward for you joining our committee, our working group, and continue to collaborate with us to make BPM Plus process to be the essential process for teaching the new students, teaching the current workforce through professional associations, as well as deploying these activities within the healthcare organizations themselves. So I would like just to conclude our presentation here by thanking those who presented today with me, and we have 5 minutes for questions, if any. Let me just stop sharing my screen and see all of you and ask for any questions, comments, or discussion points you would like to have in this remaining time.
Hey, Anna, quick question. I really like the quick walkthrough of those different use case scenarios, and it brought up the question in my mind. What do these models look like operationally, right? I mean, I can see where some of the automation can be tied to like data processes or IT processes automatically. How do you, I mean, is it just operationally you define those standards and ask someone to manage it and people to hold to it, or do you integrate the flow into the EMR, or is there another tool that would walk someone through the process as they admit, you know, someone to the ED and kind of go through this flow? Anyway, sorry, long-winded question.
This is an excellent question, and I would like to come back to our presentation and specifically to that slide that Nicole was showing to us, because that's, to me, the most essential slide. We inherited this slide from the RHIA, and you would be surprised to see that this, in fact, is RHIA Patient Care Coordination Technical Framework, under which RHIA has been developing in Patient Care Coordination Committee the standards related to care management. How to operationalize our approach is that something that we hope could be achieved in collaboration with healthcare organization clinical documentation improvement program. It didn't surprise us that about 100 people attended our presentation at AHIMA because, in fact, what you see here, the steps 1, 2, 3, 4, 5, 6, that's what's happening in every healthcare organization that deployed electronic health record. They don't use that particular terminologies. They don't know that they, in fact, are working on standards. They're just doing their job, translating best practices and clinical guidelines into the standard operational procedures or task list or checklist or clinical pathways, as clinicians will call them, to help their organization be in compliance with this clinical guidelines and safer and delivering safer and quality, safe and high quality care. And as you can see here, as soon as they develop the protocols in step 2, which is clinical pathways, they immediately jumped into that process of developing data templates. Because each step, they say, associated with particular data to be populated in electronic health record system, those data sources that they are working with the vendors to help them develop user interfaces for data capture of a particular content that they discovered or they need to populate through the clinical pathway process. And this 1, 2, 3 steps, 1, 2, 3, 1, 2, 3, that's what we informaticians constantly doing through the requirements of the information systems. But unfortunately, the step 4 and 5 not happening in that continuum. We just end with requirements or use cases development for standards, or maybe we can test standards through RHIA connectathon or different connectathons conducted by HL7 for just data templates. But to operationalize this process, we really need a way how steps 1, 2, 3, 4, and 5 could become the continuum in which every organization could collaborate. And I hope that BPM Plus could be the place where that process could be enabled through the tooling. Would like to stop here and see if my colleagues have anything to add to that.
Yes, I just want to add that once the workflow is represented, as Anna mentioned in BPMN, then we mentioned that it's actually computable. What we mean by that is that that the instantiation of what was represented in BPMN can become a real workflow, and that workflow can be implemented on any device or any group of devices throughout the organization or throughout the emergency room. So essentially, that's how we get below the technology line. Essentially, by representing all of this in a standard, we're able to then essentially instantiate that where other devices and other software tools can present some sort of user interface to the people who are using it.
Awesome, thank you.
You're welcome.
We're at the end of our time, and what I would like just to add to what just Mike said, we may see a phenomenal approach here because what you see on this picture, 1, 2, 3, 1, 2, 3, 1, 2, 3, that's how we developing standards at HL7. That's how we developing standards at RHIA. But if we right now will begin pushing this approach into the healthcare organizations through professional associations or just directly through educational activities of our clinical documentation improvement specialists and informaticians, we can enable those current workforce with a methodology that they can use, and through this business process modeling, they could begin reusing these different machine-readable artifacts that we can offer for them. I actually look forward for further discussion to see if we are on the right track and could we actually make this all happen. Join us, please, and thank you so much for your time and attention.